can go like that.
Good evening. Once again, we are with a new seminar on focus studies in breast cancer. On behalf of the organizing committee, I welcome all the faculty and the delegates. This is the seminars that we are conducting off and on for the last 2 years regularly with different topics. This time when we sat together and thought that we are trying to select uncommon but not so uncommon topics, that is the bilateral breast cancer and the male breast cancer. Initially, we thought that we don't know that how many questions and how many controversies will be there when we started discussing. But over a period of time, we came to know that there is a lot of controversies and interesting things to know about this patient and to learn about these patients, like what is the definition of this synchronous and metachronous bilateral breast cancer, how much workup to be done, what is the biological behavior of these cancers, what is the optimal surgical choices, choice of neoadjuvant chemotherapy, and so on and so forth. Similarly, male breast cancer, though looks very simple and not very common, but there are a lot of interesting questions that needs to be answered. And we have collected a galaxy of panelists whom I think in the next 1.5 hours, a lot of questions and controversies can be sorted out. Just to introduce the panelist, I have Dr. Deepak Jha. He is the Senior Consultant and Chief of Breast Surgery at the Artemis Hospital. Dr. Satyam Taneja is the Director of the Surgical Oncology at Max Super Specialty Hospital, Patparganj. Dr. Ekta Dhamija is the Additional Professor, Department of Radiodiagnosis at IRCH, All India Institute, Delhi. Dr. Alpana Srivastava is a very senior consultant pathologist at the Core Diagnostic. Dr. Kundan Singh is the Senior Consultant and Unit Head, Department of Radiation Oncology at the Rajiv Gandhi Cancer Institute. Dr. Satyam Paul is the Senior Consultant, Department of Radiation Oncology, Apollo Hospital, Calcutta. Dr. Sunu Lezer Sairek, Senior Consultant, Department of Medical Oncology at the Amala Institute of Medical Sciences, Thrissur. And Dr. Jogmaya Patnaik, Consultant, Department of Medical Oncology, Kalinga Institute of Medical Sciences, Bhubaneswar. The first topic will be bilateral breast cancer, and the moderators for this first topic is none else but Dr. Vaishali Jamre, who does not need any introduction. She is the backbone of this seminar, and Dr. Safalta Bagmer. She is the medical oncologist, and today only she has joined the Amrita Institute, which is going to open at Faridabad. Let us all say best of luck to her, and over to Vaishali and Safalta.
Yeah, thank you, sir. Can I share my screen? Yes. So once again, a very warm welcome to all the panelists as well as to the audience. And we will, I hope you are able to see my screen.
Not yet.
Not
Not
yet.
yet.
Okay. Is it visible now?
Yes.
Yes.
Just put it full screen, no?
Yes, I will. All right. So as Dr. Rajiv sir has mentioned that it's not so uncommon also to see patients with bilateral breast cancer, and we do see male breast cancers also. And during our clinical practice, we come across many such situations wherein, although it looks very straightforward, but for an individual patient who presents with bilateral breast cancer, or for that matter, a male breast cancer, we stumble a lot, and we are actually flummoxed with many different clinical situations where we need answers, and we do not find all these answers in the guidelines or the literature. So today we have actually gathered a galaxy of panelists who are expert in their fields, and now we are going to discuss many questions which come to our mind when we come across patients like this. And we are going to have a case-based panel discussion on bilateral and male breast cancer. So bilateral breast cancer case will be moderated by Dr. Safalta and me, and male breast cancer case will be moderated by Dr. Arun Goyal and Dr. Prikshi. So before we begin the clinical case, I would actually like to seek some, information from my panelists. So before I begin with the clinical case, I would like to ask Dr. Deepak Jha, how often do we come across patients with bilateral breast cancer, like either synchronous or metachronous? What is the incidence of bilateral breast cancer reported in literature, and how often do you see in your clinical practice?
If we combine both synchronous and metachronous, so synchronous would be roughly presenting either at the same time or within about 6 months of each other, and metachronous would be more than that. So it's around 12% as it is. However,
Sorry to interrupt, Dr. Deepak. We are not able to hear you properly.
is it any better now?
Yes, it is. Yes.
All right. So, like I was saying, bilateral cancers would include both synchronous as well as metachronous.
Correct.
Is of cancers at the same time or with other, and metachronous would be long period between the two cancers. So,
Dr. Deepak,
yes, sir.
maybe you could try and switch your video off. That might help because your voice is very discontinuous. Yeah.
Just give me 2 minutes, sir. Let me just re-log in again. Maybe that would help. And in the meantime,
All right. Yes, we can do that. We'll actually move on to Dr. Satyam then. Dr. Satyam, if you could take that question.
Yeah, sure, Dr. Vaishali.
Yeah.
Basically, as Dr. Deepak was trying to say, that bilateral breast cancers, it can be synchronous or metachronous within 6 months, or immediately you are finding it, or later than it is metachronous. So the incidence of bilateral breast cancer, I'll not say it has increased drastically in past few years. Earlier, also we used to see bilateral breast cases, but because of the screening programs, suppose you detect something very small in one side, the other side also you are able to detect, which we chase, and finally we come to know it is something like DCIS or something. So that's how I'll say the incidence has increased. But by and large, if we say in a year, I personally have seen at least 10 to 12 cases, or even maybe a little more than that, of bilateral breast cancer.
Yeah, so you have actually correctly said that with the improvement in the breast imaging, we are seeing more of bilateral cases, more of synchronous bilateral cases. So they may or may not be, clinically. They are mostly clinically occult, and we are able to actually diagnose them with the improvement in the breast imaging. As you mentioned that we take a period of 6 months to differentiate whether it is a synchronous or metachronous. But if you go through the literature, many studies have actually taken different definitions or different time frames to define whether it is a synchronous or metachronous. In your opinion, what should be the ideal time frame where before
what we have been reading, and that's what we say, six months we say is synchronous, basically. That's
6 months you say synchronous. Okay. I hope the other panelists also agree to this. Any difference of opinion, Dr. Jogmaya?
No, ma'am.
Same. Okay.
So like what Madam said, I think we can see studies with 3 months, 6 months, and 1 year also.
Yes.
All these options are available. So I don't think there is a specific issue, a specific time period which can differentiate this thing.
I think it depends on,
conventionally we were taught as 6 months.
Proliferation rate of that particular cancer, and depends on how, diligently breast imaging is carried out. So it can, in case if the contralateral breast is not adequately imaged, then probably we are likely to miss that, contralateral cancer, and that may be evident once it starts growing and becomes clinically palpable. It can happen like that. So, is there any particular set of patients where you feel that these patients are at risk of having bilateral disease? Is there any particular set of patients at risk of developing bilateral disease. Can anybody take this? Maybe Dr. Sunu, if you could.
Yes, I think definitely all those propensity factors like obesity and all those things would definitely play a role. But I think of late we are seeing more importance to genetic markers also for bilateral breast cancers, like the BRCA pathways and all those things. So BRCA definitely has got an increased risk for bilateral breast cancers.
Right.
And associated other HRD mutations also can have by increased risk of bilateral breast cancers.
That's right. That's right. So it has been said that because of the improvement in breast imaging, we are seeing more of synchronous bilateral diseases. Women with unilateral breast cancer have a 0.5 to 1% annual risk of development of contralateral breast cancer, and an overall 3 to 20% lifetime risk of contralateral breast cancer. It has been found that patients who undergo prophylactic contralateral mastectomy, the specimens are found to have 3.5 to 5% times, occult breast cancers have been detected in those specimens. And for metachronous breast cancers, young women who have been diagnosed with cancer for the first time, that is less than 40 years, and if they are treated very well, and if they continue to survive, they are more likely to have contralateral breast cancer. Patients with family history of breast cancer are more likely to have bilateral breast cancer, and patients with lobular histology are more likely to have a contralateral breast cancer in future. So now with this, we will move on to the clinical case presentation. So this lady is a 42-year premenopausal woman. She presented to us with a painless progressive lump for last 1 year. There's no family history and she is perfectly all right. She's healthy. She does not have any comorbidities. This is her clinical presentation. She came with a 6 by 5 centimeter firm to hard lump in the superior aspect of left breast, which was extending into the retroareolar location. And as you can see that there is nipple retraction also. Skin and chest wall was free. And clinically, there was a 1.5 centimeter mobile axillary lymph node. On the right side, an ill-defined lump was felt in upper outer quadrant. It was not very big. It was a small lump. And on the right side, there was no palpable axillary lymph node. She could be seen to have bilateral accessory breasts also, no supraclavicular lymphadenopathy. This was her mammogram. As a part of triple assessment, her mammogram was carried out. She basically presented to us with this mammogram. And as you can see here that it is, she's a 42-year lady and she's got dense breasts. So obviously, we cannot make out anything, specific on either side of the breast. So my question to Dr. Satyam would be, what will you do next? What will be your, further plan of action for this?
In case, as you've just said, the starting with the triple assessment mammography has been done, and clinically you have mentioned that the lesion is palpable on the right side also, and left side obviously it is there. So the next step will be to go ahead with the ultrasound guided core needle biopsy for both the lesions.
For both the lesions. However, we are not able to actually see anything on mammography, especially the contralateral side. The left side, the index side is definitely a palpable lump. So we can straight away go ahead.
Basically, it will be like what you are trying to ask is, if it is visible on ultrasound, I'll be comfortable going for an ultrasound guided biopsy first. But if our intervention radiologist says that he is not able to find anything and clinically we are finding something, then my next step will be to go for an MR mammo first and then go ahead with the biopsy. So
in this particular case, the same thing happened. The ultrasound did not show any, the lump was very small and, the first look ultrasound did not show any lump on the right side. So if we want to digress from this case, I would actually like to ask Dr. Ekta. Dr. Ekta, in case if, we come across patients who have a palpable lump on one side and the mammogram shows, such dense breasts. So is it is it mandatory to go for MRI, or how often do we, find occult malignancies on contralateral side?
So ma'am, this question has, are you able to hear me?
Yes.
Okay, so this question can be answered in two facets.
Yeah.
First is in the ideal settings. In ideal settings, every patient should undergo MRI when you are planning for BCS, because you want to rule out if there is anything on the other side, and you are also feeling something clinically which is not evident on mammo. And I'm taking your word that first look ultrasound also didn't show anything.
Yes.
Since practically it is not feasible for everybody, what we follow in our institute is we do dedicated ultrasound again and again in collaboration with the clinician, where they are feeling the abnormality and then doing ultrasound. That
Correct.
is what we call as focused ultrasound for that.
Yes.
So that is what is most often done.
I think you are absolutely right here. The dialogue between the clinician and the radiologist is very critical, because many a times it so happens that the area of abnormality, the suspicious area of abnormality, is not communicated very well to the radiologist, and as a result they are not able to find anything. It can happen. So Dr. Satyam, I would like to ask you, in case if the patient is planned for mastectomy on the index side, would you and clinically on the contralateral side you are not finding anything suspicious, and such is the mammogram, would you still go for MRI?
If I'm, as you've just asked the question, first of all, if we are talking about this present case, 42 years, obviously I'll be thinking of why I'll be thinking of a mastectomy on the left side. That is also issue. But if we have decided for a mastectomy on the left side, and to be sure for the right side, then also I would like to go for an MRI, so that we don't miss anything. What we have just been talking about synchronous things, we come to know 2 months later or 4 months later, then it will be a disastrous thing for us to explain to the patient.
Right. Dr. Deepak, has he joined?
Yeah, ma'am.
Okay.
Can you hear me now?
Yeah, yes. Yeah. So is there any different opinion?
No, it is a tricky situation, but yes, in case a mammography does present a picture like this, extremely dense breast, then obviously it makes a lot of sense to go for an MRI. It helps you both to plan as well as to rule out any contralateral disease as well. So yes, MRI getting is a very prudent decision.
Right. And in case the other additional advantage would be to, in case if we plan a neoadjuvant treatment, then probably monitoring response will be helped by doing MRI, serially MRI. I mean, before the start of neoadjuvant chemo and after, that will probably give us a better response assessment.
True.
So moving on, she did undergo MR mammography. It was in fact done elsewhere, and it showed a 4.5 by 3.5 centimeter lesion in the upper central quadrant, and there were multiple other small, suspicious lesions with all type 3 curves, and few enlarged lymph nodes were also mentioned in the MRI. And on the right side, again, a type 3 kinetic curve lesion was mentioned, 9 into 8 millimeter. And no associated non-mass-like enhancement, no axillary lymphadenopathy on the right side. These are the images, although they are not very good quality MR images. Then she also had undergone FNAC of left breast lump elsewhere, which was reported as fibrocystic changes with atypia. We carried out core-needle biopsy of left breast lump. It was reported as invasive lobular carcinoma. Invasive lobular carcinoma was reported elsewhere, but when we repeated a core-needle biopsy here in our institute, it was invasive ductal carcinoma grade 2 with DCIS, strong ERPR positive, HER2 negative, and Ki67 15%. Ultrasound guided core biopsy was carried out. It was initially non-representative. Then a repeat biopsy was carried out again after MRI was done, and after a second look ultrasound, it was reported as high grade DCIS ER positive. So would like to invite Dr. Alpana here, and I would like to ask her, how common do we see bilateral cancers having similar biological profile? As we can see here that both the tumors were ER positive. So what are the different biological profiles we come across in bilateral synchronous especially?
See, basically, when we are dealing with bilateral breast disease, we usually our approach is that we are dealing with two different diseases unless proven otherwise.
Yeah.
So we try to work up both the cases as a separate entity, as an individual tumor. And percentage wise, I won't be able to give you a definite figure, but in my experience, I have not seen similar biological profile too often. Most of the time, there is some difference in immunoprofile or the histology.
Okay.
For example, like in this histology, although immunoprofile seems same, but one is ductal carcinoma in situ predominantly,
yeah,
and one is invasive. So probably that is both have developed separately.
Right. So, however, in the literature, it is mentioned that nearly 70 to 80% times, especially synchronous as well as metachronous, tumors have similar ERPR, positivity, and majority of them are hormone receptor positive. In fact, triple negatives are actually relatively rarer when it comes to synchronous bilateral breast cancers. And that actually comes to the next question as to how to differentiate whether these two tumors are two different primaries, or the other side, which is actually occult or less having a lesser stage, is not a metastatic disease from the side which has got a higher stage. How do we differentiate that?
See, there are no definite points 1, 2, 3 which will help us to differentiate. It has to be combined effort and combined putting everything together. If there is completely different histology, yes, you know that if the one would have been lobular, another ductal carcinoma, then we know that these are two very different tumors. Although lobular carcinomas are known to have contralateral ductal carcinoma, that is reported in literature.
Correct.
But then they are two different, biologically different tumors. If you have ductal carcinoma, in situ changes as well as infiltrating tumor, then you know that there is local occurrence of the local event which has led to different tumor. So that is one, and totally different immunoprofile. Yes, that also helps you to make up your mind that these are two different tumors.
Yeah, that's correct. So there has been this paper which was published long ago. This is by M.A. Chaudhary et al. They have mentioned that there are certain points which help us to differentiate whether this is a second synchronous primary versus a metastatic disease. That's, as you rightly said, Dr. Alpana, it's presence of DCIS, differences in the histology, differences in the grade, difference in the biological profile, and if the symptomatic side is without having any regional or distant metastatic disease, then probably both the sides are considered to be two separate primaries. This is one of the papers which has been published by Selvi et al. And they have mentioned that there is a significant concordance for ER estrogen receptor than progesterone receptor in bilateral breast cancer. ER positivity is higher in synchronous than in metachronous. Nearly 87% of the patients are found to have bilateral ER positive tumors, and ER positivity rate is higher in older patients who are found to have synchronous bilateral breast cancers. HER2 positivity is actually very variably reported, but it is reported to the tune of 20 to 25% in bilateral breast cancers. However, TNBCs are reported to be relatively rarer. So now I'll actually hand over to Dr. Safalta to take the proceedings further.
Good evening, everyone. So I would like to ask Dr. Deepak, do you do PET-CT in all these patients, all the patients of breast cancer?
If you go by the guidelines, probably it's not still a very common investigations, but practically with the kind of patients that we get, they virtually asked for a PET-CT. So most of our breast cancer cases, especially patients with lymph node positivity, I do advise PET-CT to them, yes.
Okay. Anyone having any difference of opinion with this? Dr. Kundan, Dr.
Yeah,
Jogmaya?
actually, you see, as Dr. Deepak has already told us, definitely most of the patients, they somehow come with a PET scan. So, but as per the guideline, if we see usually T3 or node positive patients, definitely PET is required. Other than that, we can get away without PET also. But most of the time, patient himself will ask you that, Doctor Saab, PET nahi karana hai kya? So that is the clinical scenario which we always get with
Dr.
us.
Safalta, especially in this case, when you have a fairly large lesion, about 4 centimeters, 3.5, with skin, nipple retraction, opposite side, we would definitely go for a PET scan. And as everyone is saying, in our clinical practice, we are getting PET done unless and until it is a T1 lesion, a small T2 lesion, 2.5 centimeters, then it might be that we may omit a PET scan, but practically all the patients are undergoing a PET scan these days. And I think everyone is doing that.
I agree.
In case of, in this case, particular case, like the patient is having bilateral breast cancer. So do you like, even if a smaller lesion, would you like to take get the PET scan done?
Surely, I would like to get a PET scan done when I'm suspecting a bilateral lesion. There is no doubt about it.
Yes, we all agree to that. That patient underwent CT scan chest abdomen that time, and which was NAD, and whole body bone scan, which was also NAD. What further? How to go about management of this patient? Dr. Jogmaya?
Yes, ma'am, because this patient has both breast, two lesions. The right breast is having a DCIS. Left breast lesion, definitely both lesions needs treatment. So we have to first get the general blood workup done for the patient, other general evaluation. And then we have to ask the patient her wish, whether she has a wish of breast conservation or not. If she is not having any breast conservation wishes for breast conservation, then also ideally patient should undergo chemotherapy first. And before that also, because bilateral lesions are there, genetic testing should be done. Like I'd always advise this patient for a BRCA testing.
Okay, so Dr. Sonu, this patient is having ER/PR positivity in bilateral breast disease. So would you, even then you will go for neoadjuvant chemotherapy in this patient?
So I think the size was mentioned as around 4 to 5 centimeters in the left breast.
Yes.
And the DCIS in the right side.
Yes.
So depending upon the wish of the patient, especially young lady, if she wishes to have breast conservation, I think it might be a bit, I think the surgeon might be a better person to tell, but I think it might be a bit difficult to go for a BCS. If the patient prefers for a BCS, I think we should opt for a neoadjuvant. Otherwise, if it's ER/PR positive and HER2 negative, we could offer her direct upfront surgery if it's non-metastatic.
This patient is having multicentric disease in the left side. So even then, would you?
Oh yeah. Yeah. Then I don't think we should go for a BCS. I'm sorry, I missed that. Yeah. So in that case, if the patient can go for an upfront surgery, we can go for an upfront surgery.
Because this patient is having ER/PR positivity plus multicentric disease, and we are suspecting bilateral disease here. So, Dr.
Safalta, let us ask the surgeons as to what.
Yes, that's what I was.
I was about to.
So, Dr. Sayam, what you would have done? Dr. Satyam, sorry.
Yeah, Safalta. There is no doubt about it. it is not a T4 disease. There is just a nipple retraction. The size of the tumor is 3.5 centimeters. What we are dealing with is a T2N0 disease on the left side, and right side we are dealing with
No, it is
DCIS.
T2N1.
T2N1.
Okay. No, but we have not done a FNAC use.
But it is clinically, quite significantly enlarged.
Then to definitely, I would like to go for an ultrasound guided FNAC of the axillary node to go ahead for the decision of the surgery. But even if it is a T2N1 disease with ER/PR positive, HER2 negative disease, normally with the N1 positive disease, we tend to go ahead with the neoadjuvant chemotherapy these days. But with the decision, with the finding of DCIS on the other side,
exactly,
that is not going to be tackled by a neoadjuvant chemotherapy. So we have to keep that in mind. Therefore, I would like to go for an upfront surgery. But if the node turns out to be positive on FNAC, then I might think of, it all depends on that.
Dr. Satyam, this is actually DCIS on core needle biopsy.
That's what I'm saying.
So,
that it's a DCIS on core needle biopsy. On definitive histopathology, there may be some microinvasive component or a definitive invasive component in it.
Correct. So in case if you wish to go for neoadjuvant chemotherapy for the left side, I agree that it is slightly a locally advanced disease. However, considering the DCIS on core needle biopsy, what will be your plan, to prove whether this is really a DCIS, or what will you do?
Exactly, to prove for DCIS, we have to undergo the whole specimen. Otherwise, we cannot prove it in any way otherwise. So I would like to go for an upfront surgery, but for a 42 years old, we are offering a mastectomy on left side. Obviously, I'll not be thinking of too much of a conservation on the right side also. With the DCIS, I'll be offering bilateral mastectomy to this patient with sentinel lymph node biopsy of both the sides.
Okay. So in fact, we would actually want to, talk about genetic testing in detail. Genetic testing, what should be the ideal, time to do genetic testing, especially in such patients?
If you ask me, we are not routinely, I don't think any one of us are routinely advising genetic testing, because you have to wait for 15 days for the report to come, and the patient is so apprehensive that you cannot wait for those 15 days to take a decision. When the patient is there in front of you, they are like, tomorrow just get rid of the cancer. So we have to take decision at that time. If we have that thing and we can get genetic testing then, and we can wait, I would definitely want a breast panel completely, or a BRCA1, BRCA2 to see. And if it turns out to be positive, then there is nothing to think about for the treatment point of view.
That's correct. As you rightly mentioned that, genetic testing, we always advise, especially, as per guidelines, bilateral synchronous presentation definitely merits genetic testing. However, the uptake of genetic testing may not be, that high. So similar thing happened with this lady as well. She was advised genetic testing. However, because of, financial constraints, logistics, constraints also, the genetic testing was not carried out at the time of diagnosis. So it was in the absence of genetic testing result, what will be your plan for this patient? Dr. Jha can take that.
Since we are going for an upfront surgery in this patient, I think we can wait on the genetic testing part, because the maximum that we can do, even if it was a BRCA positive patient, we could have gone for a bilateral mastectomy. So in that situation, in this particular patient, it does not, we can always wait for the results to come up and we can advise upfront surgery. When we are going for an NACT, that definitely again gives us a lot of time. The only issue or the tricky part comes is that when we are planning, or the patient is a candidate for a breast conservation surgery, where a BRCA positive report can make a difference. But then,
in this patient, the contralateral side, the right side, has a very small lump, and it has been currently reported as DCIS, high grade DCIS. So what will you do for that?
For that, again, because one side, she already has a multicentric disease on the left-hand side. Bilateral cancer, as far as my advice is concerned, I would definitely ask her to go for a mastectomy on that side also.
Right side also.
Yeah.
Okay. Is there any different opinion? Dr. Sunu, would you agree to that plan of going ahead with surgery and then?
Yes, so I would certainly agree with the plan of going ahead with surgery, but the only thing, thought process would be being a multicentric disease on the left side, and now we have only a DCIS on the right side. There is a possibility that there could be multicentric DCIS also elsewhere also. One thing is, if you remove this DCIS as a breast conservation on the right side, we should go for a radiation then. In the other situation, when we're going for radiation on both sides, because the left side already has got a lymph node, so there's a high chance that there would be a need for a radiation on the left side. On top of that, if you're going for radiation on the right side, the lung toxicity also has to be taken a bit into consideration. So my thought process would be to try to avoid a radiation on one side, in which case I would prefer to go for a mastectomy on the right side.
Okay. I'm sure we are going to have that discussion about, the toxicities of radiation for bilateral side, both sides at a later time. But in the absence of, BRCA or genetic test for such a small lesion, doing bilateral mastectomy, will it not be over treatment?
Certainly it would be, means like she is 42 years. There is a multifocal disease other places. We have a DCIS proven on this side, like sir earlier what sir mentioned. This is just a core needle biopsy that has shown a DCIS. There's high chance that there could be some other components also.
Right.
My personal feeling is that if the patient is not so very keen for a DCS, I would also go in favor of mastectomy on the right side.
Okay. Dr. Satyam, in case if she wants to go for bilateral mastectomy, and at the same time she wants to go for bilateral reconstruction, then what will be your advice to her?
She is 42. It all depends on the profile of the patient. What is her work profile? It is not that we have not offered it to the patients or we have not done before. Bilateral breast reconstruction can be done upfront in the same setting. There is no doubt about that. I'll be discussing with the patient, and if patient's profile warrants reconstruction, we may go ahead with it. There are a lot of apprehensions in the mind. The post-operative adjuvant treatments are delayed because of this and other things. And in any of the patients whom we have, hardly, I'll say 5 or 10% of the patients in whom we have gone for reconstruction upfront, there have been problems in the adjuvant treatment. Otherwise, they have tolerated it well.
What will you prefer? Yes, Dr. Deepak.
Actually, ma'am, doing a bilateral immediate reconstruction is much easier and much simpler. It actually solves a lot of issues, both as far as symmetrization of the breast is concerned. The time added to the surgery is also not, it doesn't double, but it is, if it's a microvascular, it is basically an hour and a half extra because of one more anastomosis. So if she was willing to agree for a bilateral primary breast reconstruction, that will be the best for her.
Okay.
As far as over treatment is concerned, I think because there's a chance that if it comes out to be DCIS, will actually be saving radiation to one side. So probably, we can just have that advantage. So
you mean to say that you would prefer to go for autologous reconstruction over implant-based?
Absolutely.
Okay.
Absolutely. Because again, implant-based reconstructions have their own issues, starting right from availability of the adequate size. For example, you will not get an implant for this size lady. It's virtually impossible. And even if you can
always do, suggest that she might need to go slightly smaller.
Yes. So again, but then you'll have to you have to provide again symmetrization to the other side also. So on the other side, because you will be going in for the radiation, there again with implants, you have up to 25 to 30% issues and complications with that. So if she's agreeing for a bilateral breast autologous reconstruction, that's the best for her.
Right, that's correct. In fact, I would actually come to the next question about the axillary staging. If she were to, she has been reported as high-grade DCIS. Dr. Satyam, would you be doing axillary staging for her right breast?
If we are planning for a mastectomy, obviously I'll be doing axillary staging as sentinel lymph node. That's how the teaching goes. If we are doing a lumpectomy, a wide local excision, then there is no need to address the axilla at that time. But as we are going for mastectomy, that's my plan is I'll be doing bilateral sentinel lymph node biopsy.
Okay, and if she were to be positive on the contralateral side also, and if you were to operate on both the sides simultaneously, obviously she will have a high risk of lymphedema. So what will you do particularly to, reduce her chances of having lymphedema?
Reverse lymphatic mapping, and there are other things which I am not practicing right now.
Okay.
But by and large, a sentinel lymph node by dual method, a blue dye and a gamma camera are good enough, and that's what we have been practicing.
No, I'm talking about bilateral axillary dissection.
That's what I'm saying. I'll have to go ahead with it, otherwise there is no other option for it.
So the lymphovenous anastomosis can be done.
Prophylactic lymphovenous anastomosis can be done, but it all depends on the profile of the patient, very obese, and when you are looking at such patients, we can do a prophylactic lymphovascular.
Yeah, I think we should try to do, as much as possible to reduce her chances of having lymphedema in future. That we discussed. So, in fact, we also had a discussion in our MDT about this case, and it was decided to plan left mastectomy and wire localization for right breast, and sentinel node biopsy was actually performed for her. This was her surgical result, and pathology result came out to be multifocal multicentric T3N3. She was having 21 positive nodes with extranodal extension also on the right side, and on left side, and on right side it was reported as invasive breast carcinoma with associated with high grade DCIS. Margins were free and the lymph nodes were actually negative. This time again this was ERPR positive, HER2 negative, so T1B N0. Over to you, Dr. Safalta. Muted.
This patient is bilateral ERPR positive. So what will be the further management? What type of treatment will be further advised? Dr. Sunu.
Yes, thanks. So I think we will go with a plan of adjuvant chemotherapy followed by radiotherapy, followed by hormone. I think I missed that HER2 status.
HER2 negative on both sides.
Negative. So chemotherapy followed by radiotherapy, followed by adjuvant hormone treatment, and yes, hormone inhibition. Yes.
So arbitrarily, like ERPR status being positive is most common in bilateral disease. But if the patient is having one side HER2 positive and other side TNBC, how you will be giving the what adjuvant treatment will be given to this patient?
Certainly, even if it's TNBC, means we will be going with anthracycline with taxanes sequentially. AC followed by taxane is what we follow, 4 cycles each.
The patient is having HER2 positivity in the other side and triple negative in one side. That's what I'm saying.
HER2 positivity in one side and triple negative on the other side. Okay. In which case we'll be following with the same AC followed by paclitaxel with trastuzumab followed by trastuzumab to be completed along with hormone treatment.
So what about 6 cycles TCH or TCHP?
Yes, that is TCHP. The 4-drug regime is also an alternative, but that would have been better. Certainly, that could be like double HER2 blockade would be, but in my practice, unfortunately, we don't have. Means the affordability is one major issue. Certainly, theoretically, that is one good option.
Dr. Jogmaya, what will be your treatment? in this case, yes, it is standard that 4 cycles of TEC and 4 cycles of AC and then T. Then if in the case of like one side HER2 positivity, other side triple negative, what will be your adjuvant treatment?
Definitely, patient should receive, as Sunu sir said, anthracycline and taxane combination and adjuvant trastuzumab for 1 year to be completed. Both regimen are used. I also use both the regimens commonly, depending on like the dual HER2 blockade cost and all those things are also important to discuss with the patient. So wherever it is applicable, both these regimens can be tried. And this patient of TNBC and HER2 positivity on other side, they actually will receive all treatment options which are available for breast cancer. They will receive
what
chemotherapy.
about the TRAIN-2 study, which was published? The analysis, updated analysis has been published in TRAIN-2 study, which evaluated TCH versus AC followed by TH. So the thing is that, can we offer this patient a anthracycline-free regimen?
This is 42 years, so definitely anthracycline-free regimen we should try to plan, but without any cardiac comorbidities. He is only 42 years, so we can give anthracyclines also.
Okay, so actually the TRAIN-2 study which was updated, so it is like AC followed by TH. The results are almost similar to that of the if the patient is getting TCH. Here we are giving carboplatin as well, and a triple negative patient who is getting carboplatin, the benefit is more, and the oral survival benefit is almost same in both the regimes, minus the toxicity of the anthracycline. So another thing which I would like to ask, she's 42 years, she's premenopausal. So what will be, will you use ovarian suppression in this patient?
Yes, ma'am. We would like to use ovarian suppression in this patient.
So along with the ovarian suppression, would you like to use tamoxifen or exemestane?
In common practice, I use tamoxifen plus ovarian suppression, like GnRH analogs along with tamoxifen.
Okay, Dr. Sunu, would you
yes,
like
I would
to
also
give
prefer
ovarian
to,
suppression?
yes, ovarian suppression with tamoxifen would be preferred.
Okay. Dr. Safalta, now I think we have to move on because we are already lagging in time. So we'll invite Dr. Prekshi for, radiation related concerns in this particular scenario. Dr. Prekshi?
Yeah, thank you, ma'am. Good evening, everyone. So yes, we have now completed the surgery part. Systemic therapy is also completed. The patient now comes to the radiation department. My question goes to Dr. Kundan. Sir, what are the challenges do we face in planning a patient of bilateral breast cancer, be it bilateral whole breast or both side chest wall, or one side chest wall and other side breast, whole breast? What are the basic challenges do we face?
You see, with the bilateral breast irradiation, and usually what we prefer nowadays is we do simultaneous radiation for both the sides.
Yeah.
And it all depends what kind of technique you are using. So if we are actually using a three-dimensional techniques, then the matching scenarios like the junctions of both the sides, the field junctions, and those things matter. And especially in a situations where you have to treat regional nodal irradiation on both the sides, then things become quite difficult. But using a modern technique, like if you are using some sort of an arc technique or like we usually nowadays we are using TOMO in these particular scenarios. And with that, actually, we are able to achieve most of our constraint. But definitely the kind of doses which are being received by lung as well as the heart is definitely more as compared to a patient where we are actually treating with a single site lesion. So these are the two basic issues with these patients. And the other scenario is the fractionation schedule, which is like many people are like very concerned regarding if you are giving bilateral irradiation, then probably we should use a conventional fractionation. But that is not true. We have actually almost treated more than 40 patients with a bilateral breast cancer in last 3 or 4 years. And we haven't found any issues with any increased radiation dermatitis or any sort of an cardiotoxicity or a lung toxicity. So that is pretty safe. The only challenge here is with a conventional technique, you have to be very careful where your field junctions are. because sometimes it becomes very difficult to manage. There are some technical issues because of both sides of supraclavicular fields are to be matched, and then the tangents of both the sides have to be matched. But with these modern techniques, then it becomes slightly easy, but with a caveat that you increase the lung dose.
Okay. So, Dr. Sain, suppose in this patient, it was extranodal extension positive. So,
Yes.
would you like to irradiate axilla in this case, or what do you follow? Do you loosen up the indications, or they are same as that of the single side breast cancer if it is irradiated?
Yeah, this is a tricky situation. He has almost 20, I think 21 node positive and with extracapsular extension. So because of the extracapsular extension and heavy nodal burden, we have to treat the nodal areas. Like SCF, we have to treat for sure. Internal mammary chain also we should treat in this case because it has a heavy nodal burden and extracapsular extension. And in this particular case, with extracapsular extension in the axilla, probably I'll be tempted to treat the axilla, though usually I do not treat the axilla in case of axillary node positivity. But with the extracapsular extension, I might try to treat the axilla. But another situation is it's a left-sided breast, left-sided chest wall. So in left-sided chest wall and in bilateral chest walls, a DIBH technique will be helpful. Deep inspiratory breath hold technique will be helpful. And in all left-sided breast, I do DIBH. So in DIBH, treating all the nodal areas is again more difficult. Like you need to, the treatment time prolongs like anything. So you need to give more fields and you need to do the DIBH. Treatment times becomes very long. So there should be a balance in that.
Yeah, sorry to interrupt you.
Yes.
The point here is actually DIBHs will be very difficult to implement in this particular scenario where you are treating a bilateral chest wall.
Yes.
If you are using any kind of an inverse technique, then to implement that with DIBH would be practically, it is not possible. We have tried.
Will be very difficult. I agree.
Simultaneously, then also, what is your experience with DIBH if you are having a SIB plan? Both the sites you are treating simultaneously,
yes,
like by ARC therapy. So, what is your take with using DIBH in such a situation?
In ARC, like in tomotherapy, we have treated in tomotherapy. In tomotherapy, DIBH, I don't know. I mean, it will not be possible like tomotherapy.
That's what I was saying.
Yeah, in Hyderabad, I had treated bilateral breast with tomotherapy. It will not be possible. But with what I usually do is I use tangents only, but with IMRT. Like with tangents, and to get a homogeneous dose distribution, our physicists do an IMRT planning with tangents only. So the field number of fields also should be minimum as possible if we are doing DIBH, because it's not possible for the patient to hold the breath for so long time.
Such a long time, yeah. Long treatment times.
Yes, but here as we are treating bilateral breast, we should be very, very careful about the heart dose and the lung dose. So
what heart dose are you able to achieve in such cases?
See, so right-sided breast, if you are using tangents, the heart should get minimal dose. I mean, less than 1 gram, only the scattered dose. For the left side, if you are using tangents, you can achieve a dose which is less than 2 gram. But with IMC, if you are treating the IMC also, then achieving 2 gram is a bit difficult. Yeah. But what we achieve here is usually, commonly, less than 4 gram we achieve.
With the use of DIBH?
With DIBH, if we are treating IMC, and sometimes it is less than 3 or close to 2 we get. But and without IMC, less than 2 can be achieved.
Okay, and what fractionation schedule are you using? Like Dr. Kundan said, he is using hypofractionation, which is the standard of care now.
Yes, I'm also using the START protocol, that 40 15
Are you
fraction.
comfortable using hypofractionation, high dose per fraction with such a large volume? And what long-term data do we have in our hand?
Yes, so as you are treating both the breasts, so you should consider separately. Like if it would have been a single breast, the biology remains the same. So the biology remains the same, the toxicity remains the same. If in one breast, if you can get similar toxicity and similar outcome with hyperfractionated schedule, then bilateral breast also, if you use conventional or a hyperfractionated, it will be same. So the toxicity profile, if you compare bilateral with conventional, bilateral with SAR protocol, it should be same. The toxicity and the outcome should be same. So I don't think it should be different if you are using bilateral breast.
Two more issues, what is your take on the venous port? On one side, there is chemo port. So does it make any difference? Does it? It does not.
Not really. Not really. So, but coming to the previous point, actually, there are 2 points which I like to highlight. Actually, one is like axilla. So most of the time, we are not treating a comprehensive axillary radiation. If it is, we are only treating an undissected axilla. But in this scenario, because you see, extracapsular extension is a worse prognostic factor in head and neck cancer patients. But for breast cancer, I don't think there is an issue with the extracapsular extension. The only point is a heavy nodal burden. So what we follow in our institute is we have our own protocol. If it is like the positivity rate is more than 50%, then probably sometimes we include the axilla also. But most of the time we try to avoid the dissected axilla. That is a very important point. We only treat an undissected axilla because if you look at the pattern of relapses, we have gone through the literature and we haven't found any axillary recurrences in the dissected axilla for these sort of patients, despite of being a heavy nodal burden. So then we have to be very sure about that part. The other is like the port location, not really, it hardly matters. We have treated many patients with the port on the same side with the bilateral breast. We haven't had any issues with that thing. And the fractionation schedule, there is misconception, like if you are giving a high dose per fraction, then probably that will be more toxic. But there is now a lot of data which has shown that this hypofractionation schedule is in fact colder than the normal fractionation schedule, which we were using earlier in all aspects, whether being it is like a lung toxicity or a heart toxicity. So again, that should not be a like deterrent for using hypofractionation in these scenarios.
One last question. Had it been a bilateral mastectomy case and she would have gone for immediate reconstruction. So what makes you more comfortable, treating an autologous reconstructed breast or treating with implants? So what are the differences?
For me, it is autologous transplant is better than the implant. Okay. When the implant dosimetry is like, I mean, it's a bit messy.
Yeah, same with us actually. We have a sort of a not a very good experience with implant-based reconstruction followed by radiation.
So you're comfortable doing autologous reconstruction?
Right.
So earlier, there was a concept of doing a delayed reconstruction because there was some issues with radiation, but nowadays it is not an issue. Obviously, for us, it is a challenge because the target delineation becomes slightly different. That's a technical aspect. I don't think we should go into that particular detail in this particular audience.
Right.
But it is challenging, but obviously with immediate reconstruction also, there is now a lot of data. There is no issues with giving radiation with immediate versus delayed reconstruction.
Okay.
And autologous is preferred.
Over to you, ma'am.
Yeah, thanks. I think in the interest of time, we're going to skip these, questions and we'll move on. So she.
Yeah, I think Vaishali, let's finish the first subject.
Yeah.
And we
just
move on to the second subject.
Right. So just a quick takeaway on bilateral breast cancer, although the evidence is still, not randomized, and we are actually relying on the data from unilateral breast cancer. The treatment decisions are guided by individual patient profile and the tumor features. Treatment of both synchronous and metachronous are always challenging, and focus on long-term quality of life is very, very critical. And we should actually do a thorough MDT discussion at each step of management of these patients. So with this, I would like to thank the panelists and hand over the mic to Dr. Arun Goyal and to Dr. Prekshi for the further case.
Dr. Vaishali, I would like to add a comment. We have discussed this case. After discussing the whole thing, we have done conservation on one side. It's just a comment.
Yeah.
It would have been wiser if you would have gone with the decision of bilateral mastectomy and we would have not been discussing the issues of radiation toxicity and other things.
Yes.
It's just a comment.
Yes.
Nothing on the
this was discussed with the patient and genetic testing was advised. However, the patient was not willing for right-sided mastectomy. So as I said, patient's wish is also to be taken into consideration.
That's the most important.
Actually, sir, Dr. Satyam, actually that issue is there in unilateral breast also. So if we offer just because patient will require radiation, we offer MRM. I don't think that is.
No, I'm not talking. I don't offer MRM because we can omit radiation in a unilateral disease. In a bilateral disease, in a scenario like this, the patient gets by and large convinced, because mastectomy is on one side, to put conservation on one side. It is something that.
In fact, she said that what if I come out to be, BRCA negative, I would actually want to go ahead with only unilateral reconstruction. So that was also a concern for her.
So this is a tricky situation. That's why
this is a tricky situation indeed.
That's why we are discussing over it.
Yes.
Let us continue further.
Yeah.
So before Dr. Aun starts, I have a request, because there are some questions from the audience. I will ask and request my panelist to answer one of those questions. Otherwise, the audience will feel disappointed. There are some questions in the chat box by the audience. Over to Arun, please.
So I will take over, sir. I'll start. Good evening, everyone. So today we are discussing some common problems which we face in some uncommon cancers. Bilateral breast cancer has already been done. Now we move towards male breast cancer.
I think Dr. Prekshi or Dr. Rajiv was mentioning about questions related to the previous panel.
Okay.
So what I can see in the chat box, I think probably it is more about port. Where should it be placed if bilateral axilla is positive? So maybe we can have a comment from Dr. Satyam and Dr. Deepak about this.
I would just like to add a small comment over it. With bilateral breast, there is no doubt about putting it does not increase the chances of lymphedema. If we have done breast conservation on one side, I would like to put the chemo port on the right side, on the conservation side.
Okay.
Dr. Deepak.
It is mentioned that in case if the patient has to, undergo bilateral mastectomy, then
The question is, if bilateral axilla is positive, then port has to be put on which side?
That's we generally don't prefer any femoral.
Theoretically, we can put in femoral, but I don't think any one of us are practically doing it. And putting it in subclavian or IJV is good enough. And I have not seen any additional risk of lymphedema by putting a chemo port.
Correct. So maybe, the port chamber can be placed slightly lower below the area of irradiation. But as Dr. Kundan mentioned that, port placement does not make any difference to radiation. So it can be placed. And in case if, the patient has not undergone bilateral axillary dissection, then on the side of sentinel node biopsy, the port can be placed.
Fully agree to it.
Okay, Prekshi, please start.
Okay, sir. So male breast cancer, yes, it is rare. Male breast cancer comprises of around 1% of all the male cancers diagnosed. And it is around 1% of all the breast cancer cases, male plus female diagnosed. So yes, it is rare. It is understudied also. Male breast cancer is, it has been excluded from the clinical trials. And we have mostly the data which is extrapolated from the female breast cancer. So definitely it warrants some discussion, and we'll discuss one such case here today. It is about a 49-year-old male who presented with a painless lump in his right breast, which he noticed 1 month prior to the date of reporting to OPD. He did not complain of any nipple discharge, nipple retraction, or any overlying skin changes. There were no systemic symptoms, and there was no positive history of malignancy. He was examined. General and systemic examination were normal. A 3 by 3 centimeter hard lump with some areas of softening was palpable in the right breast, in the retroareolar area. There was some sort of skin tethering also present. There was no peau d'orange, no nipple retraction, and no supraclavicular and axillary lymphadenopathy. So my question goes to Dr. Deepak. How would you like to, this is the clinical picture if you want to have a look. How would you like to proceed in this case of male who is presenting with a breast lump? You are muted. You have to unmute, Dr. Deepak. You are muted.
So again, the follow-up will be somewhat similar to what a female breast lump would be. And we would like to proceed with a true cut needle biopsy and a mammogram. So these are the first two investigations that I would like to go for.
So we'll start with a mammogram and a true cut biopsy. Okay.
Yeah.
So Dr. Ekta, do we face any technical difficulties when we get a mammogram of a male breast done?
So most definitely, technical difficulty when you're asking a radiologist, I think in terms of performing a mammogram.
Yeah.
So definitely because they do not have that much volume, so it is difficult to pull them. So we have to use small paddles to compress and to incorporate as much as possible. It is difficult for them to cooperate also because it is extremely painful for them. The tissue is not that much. They do not have that much fat which can bear. Plus the lump usually which is palpable is kind of protruding out, and that itself becomes a problem while compressing. But more or less we are able to get, because we are so used to doing mammograms even in the females who have small breasts, that we get good quality readable mammograms for the male breast.
So is it sufficient, or some part of breast which is not covered, which remains unexplored in mammogram?
See, it depends on the indication now. If we are performing it for more than 25 years of years old male, and you have strong clinical suspicion that it is not gynecomastia, irrespective of whether we have done mammo or not, we tend to do ultrasound. In less than 25 years of age group, we tend to perform ultrasound beforehand. So for us, ultrasound kind of stays as a mainstay of evaluation.
So both are complementary.
Yeah.
Right. Okay. So I would like to ask Dr. Satyam, what is the role of MRI in male breast lumps?
Practically, I'll say we rarely see male breast cancer, but fortunately or unfortunately, in last 1 year, I have operated upon 3 male breast cancers, and in none of them we have got an MRI done. As we were just discussing earlier, plain mammography also is a difficult thing. So there have been patients in which without a mammography also, just an ultrasound and ultrasound guided biopsy, we have proceeded with a male breast cancer based on the metastatic workup. So MRI is not required, I'll say that.
Okay. So yes, we are done with the imaging. This is the image of this patient.
May I interrupt for
Yeah,
one
sure,
second?
sure.
See, we have to understand the concept of MR breast. We use a dedicated breast coil in which the lady lies down prone and the breast hangs in those sockets or cups. It is not possible to do the same for the male breast. So even if you would want to do, maybe that it cannot be done also. So MRI has kind of virtually no role for male breast cancers.
Okay.
So, Dr. Prikshi, just Dr. Ekta, would you say that ultrasound can be a sufficient investigation for a male with a suspected breast cancer? Like Dr. Satyam mentioned, would you agree with that?
Sir, I belong to the group of people who think ultrasound is sufficient even in female breast staging also. So it is that we kind of undermine our abilities as compared to West. We are very good with ultrasounds.
Yeah, that's a very
and
nice
practically in all
statement.
females also, all mammographies are correlated with the ultrasound in most of the setups.
Absolutely, sir. Even if we are able to see a mass like in front of us, until and unless it is just T1, T2 with nothing in the axilla, we might just let it go because it is speculated and definitely by RADS5. Otherwise, we perform a complementary ultrasound for almost.
And let me ask you something else. See, the main advantage of mammography comes when we have microcalcification.
Yes.
So what is your experience with finding microcalcification in male breast cancers?
Very rare, sir. Not
Very
that
rare.
usual. Yeah.
Not that usual.
Because it is the ductal component. So by virtue of the composition of breast, it is highly unlikely that we tend to see that kind of pattern in male.
Okay.
It goes back to the pathology.
Okay. Yeah, please, Dr. Prekshi.
So this is the X-ray mammogram of the patient. And we can see that on right side, there is a well circumscribed lobulated dense mass. It was BI-RADS 0. A complementary ultrasound was done and it showed a solid cystic mass of size approximately 37 into 31 into 42 millimeters with a solid component on one side, which was having irregular margin and increased vascularity. It was suggestive of BI-RADS 4. So with this X-ray, mammogram, and ultrasound report, Dr. Satyam, what would you like to go ahead with? Will you like to have an FNAC or a biopsy will be the standard of care as in cases of females?
The
What is
biopsy
the
is the standard.
reliability of
The biopsy is the standard, ultrasound guided, image guided. Let it be male or female. There is no doubt about that. No doubt about it. And even if you are saying ultrasound is showing no axillary lymph nodes, if there is a suspicious lymph node in the axilla, FNAC should be done from that also in the same sitting.
So, okay, you mean we have to, yes, that was actually my another question. How will you like to assess? Is the clinical assessment enough, or will you like to go ahead with an ultrasound axilla in each and every case for the axillary assessment?
Practically, I'll say for all my cases, I'm getting all ultrasound guided biopsy done for the breast, and in the same sitting, I'm writing, if you find any suspicious node in the axilla, please do a FNAC from that also.
Okay.
So all patients are undergoing a axillary assessment also in the form of ultrasound.
Okay. So, yes, you answered my question that a core needle biopsy is the investigation of choice, and definitely if ultrasound guided, it should be ultrasound guided. In this patient, it came out to be invasive ductal carcinoma grade 2. So I would like to ask Dr. Kundan, what...
Dr. Prekshi, just I'll interfere here. Maybe we can ask Deepak. Say in women, we have generally a standing arrangement with the radiologist that when they are doing a biopsy, maybe to place a clip, or so in males, do you think is there any purpose of asking for a clip placement at the site of biopsy or in the axilla?
Not really, sir, because generally the breast fat is so little. If we are talking about NACT, usually the lump is going to be a much larger lump. So, and plus it is very, very, very rare to have a male breast patient who's actually going to be a candidate for a breast conservation surgery. So probably just, yeah, so just save some money and go ahead.
Yeah, okay. Please, Prekshi, yeah.
So, Dr. Kundan, what are the staging investigation we like to go ahead with in this case?
I think it is like a early stage node negative breast cancer. So I don't think we need a very extensive PET scan as we have discussed earlier. If already patient has done a PET scan, then that's a different scenario. Otherwise,
actually, yes.
That's a difference. Otherwise, X-ray chest and USG abdomen is more than sufficient to go ahead with this thing.
Yes.
The other thing is, along with the biopsy, we should do again, as discussed earlier, we should do a genetic testing in this particular patient also, along with hormone receptor and HER2 status.
So, okay, yes, PET scan has already been done. He reported to us with a PET scan report, and it showed early stage lesion with no lymphadenopathy. So I would like to hand over to Dr. Arun Goel, sir.
Yeah, so I think these are some questions I wanted to discuss, not specifically related to this case, but because it is a disease. Otherwise, we tend to treat it in a manner similar to breast cancer in women. But just to highlight if there are any differences, and Dr. Alpana, I would like your inputs here. One is about the pathological spectrum of male breast cancer, if you can highlight for our benefit.
Yeah, basically, disease as such, the malignancy is very similar to female breast cancers. It's just that in females, we have spectrum of histopathological types which we can see in female breast. In male breast, infiltrating duct carcinoma is most common type. And of course, and papillary. These two are the most common types you encounter. But and higher stage. Probably they are associated with lots of molecular abnormalities. That is why that may be the reason. But usually under microscope, disease looks more aggressive than regular female breast, average breast cancer.
So have you come across lobular breast cancer in any male patient in your experience?
No, not yet. Not yet. I have not seen, although literature says up to 2% can be lobular carcinoma, but I have yet to see one lobular of male breast.
And if we were to order immunohistochemical testing in a male breast cancer, what would be your recommendation?
ER, PR, HER2/neu, AR, if I think if it helps in you deciding hormonal therapy, yes, AR, PR, HER2/neu is regular, plus AR and Ki-67, of course.
Okay. Maybe we can ask from our medical oncology colleagues, Dr. Sunu, do you think AR testing is going to help you at some stage?
Currently, as of now, we don't do that routinely out here. And it's not, means like the benefit might be like in situations where we want to use something like a bicalutamide or so. It might be, in rare situation, it might be beneficial. We usually do not perform it routinely. We usually go with ER, PR, HER2/neu.
So yes. If AR testing has to be, so if you consider, say, therapy directed towards androgens, then you would get testing done later on? Is that so?
Yes.
Okay. And Dr. Alpana, let me ask, say, in breast cancer in women, the intrinsic subtypes based on the genomic profiling are quite well established. So in men, can we say that it's an analogous situation, or is it any different?
There are lots of different differences described, like P53 mutation is mentioned in, I think, 90% of the cases, as compared to around 30% in females. And methylation, high methylation status, MSH are also have higher incidence in males than females. But I don't know if there is any intrinsic study done in India which has shown. We'll have to search for it. I haven't come across any intrinsic Indian study which has done genetic profiling of male breast cancers.
Dr. Jogmaya, would you have any comments on this issue about whether we should consider, say, a description of luminal A, luminal B and all? Can we use it like similar to women in male breast cancer or no?
Sir, actually data for this molecular subtyping of male breast cancer, as madam has said, it is very sparse because most of the studies are retrospective. So because of that, mostly 80 to 90% cases of male breast cancer have ER receptor positive. So mostly they are, in a majority, they are luminal A type. But concrete data on the luminal subtyping for male breast cancer is not there as like female breast cancer.
Okay. So, Dr. Prekshi, I think that is right now about pathology. So we can go ahead with the next.
I would like to ask Dr. Arun just a question. We are getting, all of the panelists are getting ER, PR, HER2/neu, Ki-67 and AR done in male breast cancer. That's what I'll perceive.
I am not getting AR done as a routine. The other four is standard for me.
Okay.
So, Like Dr. Kundan said, that genetic counseling is very important in male breast cancer also. Theoretically, yes, each and every patient of male breast cancer should be sent for genetic counseling. However, practically, what are you doing? My question goes to Dr. Sonu, please. Are you practically sending all the patients?
No, we don't send practically every patient for genetic counseling, but definitely if there is a family history of breast cancer in any other near first or second degree, we do send for genetic counseling and testing. But ideally speaking, I think we should be going for genetic testing for all the patients with male breast cancer.
Okay. And what is the best time at which these patients should be sent for genetic counseling?
I think the best time would be immediately once if we are going for an upfront surgery, might be after the upfront surgery, we could go send them for genetic counseling. I think that would be the best time.
Okay, my
because practically in the initial time when the patient comes and when we have the diagnosis, it might be a bit difficult for them to accept the genetic counseling also at that point of time. But once they are into the treatment, their acceptance rate would be a bit more better for genetic counseling.
Okay, so NACT is also being used less commonly in male breast cancer. So definitely, yes. My question goes to Dr. Sain. What is the role of fertility counseling in male breast cancer cases?
Yeah, so if the family is not complete, then we should do fertility counseling because the patient might need chemotherapy and that can cause that can have some effects on the male fertility. So we should do a fertility counseling and we should inquire about the planning of this particular patient, family planning issues. And if possible, then we can do some kind of sperm banking also before starting chemotherapeutic drugs.
So even
can I just ask Dr. Sain? That's a very good point. So can I just ask? In my practice, most of the male breast cancer, everybody are very elderly patients.
Right.
How frequently do you get a young male breast cancer patient?
See, in last 1 year, I have treated only one male patient, and he was, I think, around 54 years old. So this question didn't arise at that time.
At least we should have a discussion with the patient.
Yeah, we have to ask the question actually.
Whether he needs further.
Right.
Yeah.
Can I just ask here, maybe Dr. Sonu and Dr. Jogmaya, about genetic testing results? Do they impact any of the treatment decisions for the index cancer?
So definitely genetic testing should be done because more male breast cancer cancers are associated with BRCA2 mutation. And if the patient is non-metastatic, then it probably does not affect the treatment decisions because mostly male breast cancers undergo MRM. There is no question of breast conservation in male breast cancer, very rare. So in non-metastatic cases, it doesn't hamper the treatment decisions. But definitely the family members and counseling, risk counseling to the family members, all these things are important so that they know that this is a genetically predisposed patient and because of that he developed the cancer and other family members are also predisposed.
The benefit which arises in the setting of HRD impairment in women also, probably it is more seen in triple negative breast cancers, while most of the male breast cancers are HR positive. So can we translate those results to males?
Yes, sir. Mostly because this is the incidence of male breast cancer is so less. So most of the genetic data of female breast cancer only is extrapolated to male breast cancer patients.
Okay, let's go ahead. Yeah, so here let's ask Dr. Satyam and Dr. Deepak. Dr. Satyam, what would you offer this patient?
It is a early disease with a node negative, as I remember the findings were. So we'll go for a upfront surgery, a mastectomy with a sentinel lymph node biopsy for this patient.
Okay, now Dr. Deepak, do you think a breast conservation surgery has a role in male breast cancer? Say in India, we do have some reports from the West about 5 or 10% cases being treated with BCS. Do you think there is a role in India?
So role definitely is there, because again, if you think about the cosmetic deformity, it is indeed impactful, because losing the nipple becomes a little difficult. Accepting that is a little difficult for a male patient. But at the same time, the lines have quite blurred, because unless and until we get a patient that has got excess of breast fat, BCS is pretty much impossible. Sometimes we get a very upper pole tumor, which is far away from the nipple area. And then again, whether you call it a breast conservation surgery or you do call it a nipple sparing mastectomy, that again becomes a very complex issue. Because we can always go in for a nipple sparing mastectomy in the males.
So I think one of the issues is definitely most of the tumors are central, because the whatever breast parenchyma is there is mostly retroareolar in location, unless the patient has gynecomastia. Let us say that for a discussion sake, if a patient has on biopsy a DCIS, would you recommend a mastectomy even for DCIS so the patient can avoid radiation?
Yes, so we can easily go for a nipple sparing mastectomy.
You can
in
go
males.
for in males.
Definitely.
Satyam, you would agree with that?
Yeah, I would agree with that.
Okay. And axilla, you would translate the results of whatever is available in women. So we do a sentinel node biopsy whenever the nodes are not clinically involved.
Same way.
Same way. And then can I ask an extension of that? So we have axillary de-escalation going on in a big way with the Z11 and other trials. So if we have a low burden of disease in the sentinel nodes, how do you decide? Would you avoid a axillary dissection? Suppose 1 out of 3 nodes is positive.
In sentinel, if 1 of the 3 nodes are positive, still there is no point. There is de-escalation automatically. There are Z11 trials and other things going on, but it is too early to say, because when we are talking about male breast cancer, that automatically is a more aggressive kind of a breast cancer, as we've just discussed. So I would not like to de-escalate the treatment in a male breast.
So you would not like to. Dr. Deepak, do you agree that male breast cancer is more aggressive, say stage for stage, or matching prognostic factors?
No, I don't agree. I think it behaves in pretty much the same manner. The more problematic part is making the patients adhere to the treatment. I think that could be one of the reasons why we are having lesser survival rates, but it's not more aggressive stage by stage.
I think that is an interesting point. Dr. Sunu, do you think male cancers are more aggressive?
I think male breast cancers are a little bit slightly more aggressive, but that might be biased by the fact that the numbers are really very less. And if you see 1 or 2 more aggressive cancers compared to the numbers in females, it might not be a real. So I think it's mainly related to the number bias.
Dr. Arun, but if you'll see the Ki67 of all the male breast cancers, you will always be finding a high Ki67 percentage.
No, I don't know. See, the thing is about more than 90% are ER/PR positive. But the thing is that the CR data shows that the hazard ratio for death in male breast cancer is about 1.4. Only question is whether it is a difference in biology or it is a suboptimal treatment because of lack of adequate enough data, and maybe decision-making issues may be there. So definitely that fact needs to be clarified in terms of biology and in terms of optimal management. So let us go to the next.
Majority of the breast cancer, male breast cancer patients also present in stage 3 or stage 4, because they present in advanced stage. So that may also affect.
No, but definitely a stage by stage comparison also shows that the hazard ratio for death in men is higher. So to an extent, there is something which is not explained. Dr. Prekshi, can we go to the next slide? So this patient had sentinel lymph node biopsy along with total mastectomy. 2 nodes were identified. They were negative for metastatic disease. Next slide. So this is the marking. This is the sentinel node. This is after removal. Next slide. This is a specimen. Just to show here that we removed part of the pectoralis major muscle, which was where the tumor seemed to be adherent. Now, let us say, Dr. Satyam and Dr. Deepak, would you say that as a matter of principle, because there is not much of fat, should we be doing something like a radical mastectomy as a routine, or we do whatever is required ad hoc on the basis of findings?
Only what is required. If
Only
you
what
feel
is
that it is
required.
there, yeah, if you feel it's there, then it obviously makes more sense to take off some part of pec major along with it, but
Okay.
not if it is completely, if you can see a clear plane.
Not
What
as a
you have-
matter of principle.
What you have actually done is when you are dissecting, you feel that there is not
Yes.
good enough a plane you are finding, take a small chunk of peg major along with it, what you have
Yes.
just done and shown
Yeah.
in the specimen. That's the right way to go about.
Yeah. Okay. Thank you. Next slide, please. So the pathology, we had a cystic lesion 4.5 centimeter, but a solid component of 1.5, invasive carcinoma grade 2, 1.5, dermal LVI was present, but otherwise the tumor did not show LVI. There was a small component of papillary neoplasm and a small component of DCIS, notes were negative. The pathologist reported T1C N0 SN, so a grade 2 invasive carcinoma NST. Next slide. This is the immunohistochemistry report. Dr. Prekshi, I think you can take over from here.
Yes, sir. So the patient has underwent MRM. Now regarding the adjuvant therapy, Dr. Sunu, what do you think, what chemo regimes are being used in male cancers, and what is the benefit? Is the benefit same as that of the female breast cancer?
Yes, the regimes, almost all the regimes are chemo regimes are almost the same. Endocrine therapy might only differ a little bit. So the benefit also seems to be, means with whatever available literature is there, we don't have an exact data to tell that the benefits are as good as or as worse than what is there in female breast cancer, but it seems to be as good as in female breast cancer also. We use the anthracyclines, we use the taxanes also. And if Herceptin, if HER2 positive, we use Herceptin also.
Okay, so Dr. Jogmaya, if it is HER2 positive disease, then what do you advise to this patient? Single trastuzumab or a dual blockade in the form of pertuzumab and trastuzumab?
Definitely, the chemotherapy regimens and the planning of anti-HER2 therapy in male breast cancer is same as the female breast cancer. So therefore, as for the current guidelines, definitely dual HER2 blockade as adjuvant therapy can be given to the patient. And definitely this patient warrants chemotherapy and followed by hormone therapy.
So it was T1C N0. Would you like to have a genomic profiling of this patient done, or you will stay straightforward go with chemotherapy?
Ideally, a genomic profiling test assets like Oncotype DX or CanAssist or MammaPrint, this thing should be done.
Dr. Sunu, what is your take on this?
Yes, ideally, theoretically, we could do this 1.5 centimeters, almost reaching the 2 centimeter mark. So the benefit might be, means like, most likely it might go in favor of a chemotherapy, but certainly this is an indication where we should do a Oncotype DX, etc. A genomic profile, especially if the patient is apprehensive about chemotherapy, it should definitely be done.
Can I just ask a question? Suppose patient is not very keen on chemotherapy, doesn't have the money to go for Oncotype DX. Would you be happy accepting treatment without chemotherapy, or would you support a patient in that decision?
Right. If it's ERPR positive, HER2 negative, the Ki67, if it's a little bit low, and if the ERPR status are like the scores are really high, like 7 or 8, if the patient is really very apprehensive about the chemotherapy, we could go with hormone therapy, endocrine therapy.
Dr. Prekshi, can we just go back to the ERPR findings here?
8 by 8.
So this is the findings in this case, Dr. Sunu.
Correct. Yes. So I think means if the patient is really apprehensive about this, and if they can't afford the Oncotype, I think this is a reasonable option.
This is a reasonable option. Okay. Okay. Yeah, please.
So, what endocrine therapy will you like to go ahead with in this case, or in any male breast cancer?
So that might be the only difference where there is between a male and female breast cancer treatment, where most of us always prefer to go with tamoxifen, especially when there is no postmenopausal status in males, and we don't know exactly related to the hormone status from the testis even at this age. So tamoxifen would be the first choice always. If the patient cannot afford tamoxifen, we might go for an AI with the androgen blockade, estrogen blockade.
Pardon, and what is the indication of AI in male breast cancer?
If the patient cannot tolerate side effect related.
Okay, okay.
5 minutes.
Do you, Dr. Jogmaya, do you use AI? Have you used AI in any of your male breast cancer patients?
No, I have not used.
And suppose if it is to be used, then do you use it? Will you like to use it alone or along with GnRH analogs?
No, AI should never be used alone in male breast cancer. It should always be combined with GnRH analogs. Otherwise, that increases the testosterone surge.
And what is the optimal duration of endocrine therapy in male breast cancer?
Ideally, it should be for adjuvant therapy should be for 5 years, but additional 5 years of endocrine therapy can be given in high risk patients, like if very large tumors, like 4-5 centimeter tumor or high nodal burden, endocrine receptor negative, positive, but the scores are less, like the ALRAD scores are less. So in those group of patients, there is high risk of recurrence, or the Oncotype DX recurrence score is high. So in it is higher in the endocrine range. So in those patients, we can use for 10 years also.
Okay. Dr. Sunu, what is your experience with the use of anti-androgen therapy, medical and surgical, in male breast cancer cases?
We didn't have to, means like in the last 2-3 years, we had only around 4 or 5 patients. None of them we had to use an anti-androgen blockade at any point. That means most of them are still going on tamoxifen itself.
Are there any particular indications in which subset of patients should we use anti-androgen therapy?
One indication might be really when the patient means like AR receptor was positive, or I'm not sure if there's any other indication for anti-androgen blockade per se.
Okay, Dr. Jogmaya, your experience with the use of anti-androgen therapy?
I don't have any experience with anti-androgen usage, but one indication may be when it's a hormone positive disease and androgen receptor also is positive, and we have exhausted all our endocrine therapy options. In those cases, we can try androgen receptor blockers like bicalutamide, nilutamide, all these things we can use.
Okay. So coming to radiation, Dr. Kundan, what are the indications of radiation in male breast cancer cases? Are they different from females or?
Not really, actually. I think we extrapolate from the same as in females. The only issue is for node negative T2, if there are some high risk feature, because you see the breast tissue is very, very less, and sometimes the margins becomes very close. So that is something which we have to see the dermal involvement. That is something we have to take care of it. Otherwise, the rest of the all indications are exactly same as in female. I don't think.
So you believe if suppose it is BCS and early stage breast cancer in male, it should be given radiation?
Yes, it should be.
Yeah, but it is underutilized. What is your take, Dr. San? In BCS cases or even in mastectomy cases, many times radiation is underutilized as per some SEER-based data and some NCDB studies.
Yes, but in this case, like it is less than T2, it is less than T2, it is T1C, and hormone receptor positive, no node positive. So in this case, radiation is not indicated. I mean, in this case, we can avoid.
Not in this case. Suppose, do you use some soft indicators of radiation as we use in female breast cancer when it is T1, T2, and 0, and we use like LVSI, age of the patient, and all these factors we use in females. So should we use these factors in males also, or suppose it is T1, T2, and 0 mastectomy, it can be definitely exempted from radiation?
Yeah, it may be the higher grade and node negative state. I mean, hormone receptor negative status can be 2 issues, 2 risk factors where we can think of giving radiation. Otherwise, it will be like same as the female breast cancer.
And the toxicity profile, what is your comment, Dr. Kundan? In male and female, is there any difference? Do we need to take some extra care or?
Not really. The only thing is, again, you see, we have to irradiate the chest wall, and anyhow that is a very thin chest wall which we have to irradiate. So we have to make sure that we are not missing any of that chest wall. So the impact of bolus is also very important in this particular scenario. And rather than the toxicity, again, it all depends what dose constraint you are able to achieve. And I don't think there should be any issues if you're using a proper planning and everything. So with that also, there should not be any issue.
Any other issue
for your last question, if like T1, I don't think we use any kind of soft indicators, but with T2, then if most of these lesions are centrally placed, along with that, if there is any other one or more of any other factors, like if it is a triple negative, LVI positive, these are the factors which are there, then probably we should discuss, because in these particular subgroup of patients, in females, we have seen there is a lot of locoregional recurrences. So these are the only subgroup of patients where you can actually discuss with the patient. Again, that is not a sure shot indication for radiation.
Okay. So
I think basically just one question and then we can wrap it up. Satyam, say in a male breast cancer follow-up, do you think a contralateral mammography has a value?
Practically, as I said earlier, also mammography, I would not be too bent upon to get it done. A basic ultrasound of the opposite breast is good enough. That's what I'll say.
Okay. So Deepak, what would you say? Clinical examination alone can suffice, or some imaging should be done? Yeah.
Absolutely, sir. Clinical examination in a male would be more than enough.
So maybe a clinical examination alone, or at most a ultrasound, a mammography may not be maximum ultrasound. So I think we would sort of wrap it up.
Can I ask one question? Am I allowed?
Yeah. Please.
So Dr. Deepak and Dr. Satyam, is there any role of contralateral risk reducing mastectomy in a BRCA positive male breast cancer?
You've asked again a very tricky question. There is no doubt about it. There is definitely a role theoretically, but we have not faced such a situation. If I'll face, I'll be offering it. There is no doubt about it.
Okay, let me then counter this statement here. When we talk of contralateral mastectomy as a risk reducing intervention, in women, we say that the risk of contralateral breast cancer is say 20% or 25% in a BRCA mutation carrier. Now, in a male breast cancer, the total risk of breast cancer in a mutation 1%. Carrier is not more. In BRCA1, it is what 2%. In BRCA2, it is up to 7 to 10%. Yeah. So contralateral risk also is not going to be higher than that. So probably the total risk which is there is not that high. I don't know. Yeah.
They carry a lifetime risk of 6%, so probably not much role. And apart from BRCA, actually, for other they don't even advise testing for the other genetic mutations in male breast cancer.
Basically, in male breast cancer, on follow-up, it can be detected early also. So a question of prophylactic risk reducing mastectomy also has a limited role. That's the reason.
Yeah. So maybe more of sensitization and
yes.
Surveillance with maybe a regular ultrasound might be a good thing to do.
Yeah. Thank you. And I think we'll hand over to Dr. Dinesh Singh sir for the parting comments.
Prekshi, can you unshare your slide?
Yes. Good evening, everyone. And I really enjoyed the deliberations and the discussions we had in these topics. These are somehow uncommon topics which are not discussed in the routine conferences, and that is why they have been taken up. Now, both of these situations in which there is a bilateral breast cancer and in which we have to go for individual assessment of the patient, whether it is synchronous or it is metachronous, whether genetically same or different on both the sides. And then these are having challenges both in the surgical side, into the chemo and hormone therapy, and the radiation side, and all these were deliberated in length. Also, we discussed about the male breast cancer, which is mostly treated as the female, but there are some issues which needs to be looked into, especially like the hormone therapy which has been done, and the role of androgen receptor, how common or how important it is in the times to come. I hope all the attendees, they have gathered some knowledge from these things. And I would like to thank all the panelists, and they have contributed immensely to the success of this conference. And thank you everyone from the organizers. Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you, everyone.
Thank you.
Thank you.
Thank you.